And welcome to the Dr. Bob Show. We'll be spending most of this show talking about Parkinson's disease. It's a neurodegenerative disease with some classic motor signs and symptoms. It's the same disease that Michael Fox has, but there's some new information now that maybe early diagnosis can improve the lifestyle, and the diagnosis of Parkinson's will not be as devastating as it is now. My guest is Dr. Michelle Brewer. Dr. Brewer is a board-certified neurologist, and her passion is Parkinson's disease. She'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about a connection between obstructive sleep apnea and obesity, why one seems to feed the other, and new types of asthma that are leading to new types of treatment to help people with asthma. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Michelle Brewer, board-certified neurologist, and we're going to be talking about Parkinson's disease. Michelle, welcome to the Dr. Bob Show.
Thank you.
How common is Parkinson's disease?
Well, there's over 1 million people in the United States that have Parkinson's right now, and it's predicted to double in the next 10 years.
Is that because people are going to be getting older, or we don't know why?
We're not sure, but we think part of it is the aging population. It's the baby boomers are coming of age of Parkinson's disease now. And so they think in 30 years it may be tripled because of that group coming and getting older and living longer.
I've seen some people with Parkinson's, and they have some classic neuromuscular findings. What are those? And then we'll go to some other stuff.
It's the motor findings is what we've talked about for years, and they are asymmetric tremor, a resting tremor in their lap, a rigidity, which is stiffness of the limbs, the arms and legs, and then bradykinesia, which is slowness. So they have a slowness of movement, and then postural instability. So they start getting some issues with balance early on when they make turns, when they're walking.
What's characteristic of the tremor?
The tremor is a resting tremor. It's a lower amplitude tremor, and it's usually in their lap. And when they use their hands, it will go away.
So you can reach and you can grab, but when you put your hands in your lap, the tremor starts going about this speed, somewhere in there?
Yes.
Is that why they call it a pill rolling tremor?
Yes, it's because the old pharmacy thing was rolling pills, and it starts in the thumb. So a lot of times it'll just be a thumb tremor, and then it'll involve the thumb and first finger and start doing, that's why they got the pill rolling from, and then the whole hand becomes involved.
And tell me about the muscle rigidity. What's characteristic of that? Does it mean you just can't move it good, or it's...
It's stiffness. The earliest sign is a decreased arm swing, where when they're walking, then one arm doesn't move as well as the other, and the family will notice it and notice that one arm's swinging and one arm's not, and that's one of the early signs. So they sometimes complain of shoulder pain because the arm's stiff and not moving. But it's also called cogwheel rigidity, because when we check them, it's like going through the cogs in a wheel. You see this movement, this ratcheting movement with the stiffness. So it was called cogwheel rigidity.
What's going on that makes that occur? That makes the rigidity, that makes the tremor, that makes difficulty with motor actions?
It's the motor system, the secondary motor system. There's no weakness with Parkinson's, so it doesn't affect the primary system. But the secondary system is the system of repetitive movements and your ease of movement, fluidity of movements. So that's the one with the slowness and the stiffness and rigidity.
Now, there are some new findings that may help change the treatment or the diagnosis or the lifestyle of patients with Parkinson's. Let's jump into that now.
Maybe several of those. The newest thing is, besides these motor symptoms, which we've always taught people to look that these are the symptoms of Parkinson's disease, we knew by the time they came in with those symptoms or started with the tremor or the slowness that they'd already lost 70% of the brain's dopamine. So it was a tipping point,
The
basically.
brain's dopamine. So that's a key, the dopamine?
Yes.
Where is it in the brain?
It's in the basal ganglia typically, but other areas now that we found too. But that was the typical area of motor movement. And it comes from the substantia nigra, which is in the back of the brain. And what's happening in Parkinson's is a progressive neurodegenerative disease, so they're losing cells early. The cells are dying out that make this chemical. And dopamine is what we call a neurotransmitter, which means it's a chemical that helps transmit signals in the brain.
So if the cells die, no dopamine, patients get the signs and the symptoms. So what are the new findings that are going to help us?
Besides those motor symptoms, we knew that patients came in when we had clinics for Parkinson's disease that they had a lot of other symptoms, and they were non-motor, so they weren't involving the motor system with movement. They were things like constipation, decreased sleep, insomnia, depression, sweating, REM sleep behavior disorders, the loss of your sense of smell. They would have seborrhea around the face, so the skin system was involved. Other systems were involved besides the brain. And we knew they had these, and we used to treat them with them as well, and the medications didn't seem to treat them as well. But now, just as of 6 or 7 years ago, we found out by a pathologist who looked at where the pathology in the brain is with the Lewy body in the cells, and he found that, lo and behold, it started in the olfactory bulb.
That's where the smell
sense
is.
of smell. And then it went to the brainstem, and that's where all the sleep disorders came from.
Wow.
And then it went to the basal ganglia, which was the motor system. And then from the motor system, it goes into the cortex, or the upper areas of the brain, which are involved with memory. So that's why they would get a memory issue late in the disease. And we knew those two pieces of the puzzle, but we didn't realize that those things we saw associated with it that are non-motor are the earliest findings of Parkinson's disease.
So if somebody's having difficulty with their sense of smell, that they're having lots of sweating, that they're not sleeping well, that maybe they're getting depressed, how in the world does that turn on a light for a physician to say, you may have early Parkinson's and we need to get to work?
Well, actually, we're looking for screening things now because we have drugs on the horizon that will slow the disease down for the first time ever. So now there is an interest in trying to find them earlier because they lose this chemical for 8 to 10 years before they develop a tremor. So they've had this disease for some time by the time they come in, typically. Now we know if we can catch them with screening for these non-motor symptoms, we may be able to treat them early before they ever get to the 30% loss, and we would be treating them at a higher level of dopamine.
So if somebody their smell is not good, from an allergy standpoint, we think of nasal polyps that are in the nose, sinus disease, we get a sinus x-ray. If that's all clear, then we need to be thinking about the possibility of early Parkinson's?
It could be, yes. I mean, we're looking at several of those, and that would be one of them. And we know it can happen from other things. Head injuries can cause it, sinus disease, other things can cause it. But if you have several of these screening factors over time, and now we have a new scan, as of several years ago as well, it's called the DAT scan, or the Dat Scan, and it shows dopamine transport. And so that can be, if that's positive, there's a decreased dopamine transport in the basal ganglia. So that's going to be helpful so that we don't have to wait 10 years to see how good the screens are.
How sophisticated is the DAT scan? DAT scan.
It's very good. And we have one in Knoxville. UT has the Dat Scan available.
So if if somebody is seeing somebody with sense of smell problems, or with depression, or they're having trouble sleeping, does the sleep specialist look for this? Does the ear, nose, and throat doctor look for this? Or does the primary care physician? It looks to me like when we're looking in the back, we're seeing these things, and we've got to figure out how to look forward.
Yes. And when we get those screens, we will tell everyone, but it's going to involve probably the REM sleep behavior disorder, which is highly associated with it. And it doesn't take a sleep clinic to diagnose that. And the sense of smell, So those will be some of them. Constipation will be very difficult because it's too ubiquitous. I mean, it can be caused by their diets, their medications, numerous things can cause it. So I don't think that will be a screen. And we're looking at the autonomic system because of the sweating and the bowel and bladder issues, bladder control issues and things. So that system's involved very early. And so that may be another area we're looking at. But there will be documented screens that you will know the three things are the ones to look for, because some of them we can't use all of them.
If we can find Parkinson's disease early, is there treatment that can help the people?
Not yet, but it's coming. So right now.
And that's what we're going to be talking about. Not yet, but it's coming. Dat Scan will be available. Trying to find the diagnosis with certain criteria early, and then we have treatment that can help. It's the most exciting thing I've heard. You'll want to stay tuned. We're talking with Dr. Michelle Brewer, board-certified neurologist. We're talking about Parkinson's disease. We're talking about a neurodegenerative disease where it involves the midbrain or the substantia nigra. It involves depletion of dopamine, and when that is depleted, you start getting pill-rolling tremor, you start getting muscle rigidity, you have difficulty starting movements. But now we're learning that there's early findings with smell, with REM sleep, with sweating, lots of new screening, a new scan that shows. It's blowing my mind here, Michelle. Is that a good overview so far?
Yes.
Let's talk about treatment. How do we treat now? The problem is dopamine?
Yes.
So teach me.
So it's always been a replacement of dopamine. They're losing dopamine, we give them dopamine back, and it restores their motor function. So it works very well on those symptoms of the motor disease. Their walking, their tremor, their handwriting, their voice is softer, the voice will get stronger with dopamine, they will straighten up, the posture will straighten up, the tremor, like I said, will decrease, but their movements will be better, and especially their walking, with the shuffling slow gait and the bent knees and that type of thing. Everything will improve motor-wise with dopamine. So it's always been the mainstay. When they discovered that dopamine was what they had lost, giving them dopamine was a dramatic change in their functioning. So that's been the mainstay. But the question is how to keep the dopamine in their system all day long, because the brain is used to seeing a continuous level of dopamine. And now we have pills that are very short-acting dopamine. And so we're giving it and it's pulsing it, which causes them to have some late-term effects from long-term dopamine replacement.
So there's no free lunch, as we've always said. Too much pulsing, dosing episodes of dopamine replacement. What are the side effects that it causes?
It causes long-term motor fluctuations. So the receptors see this, and so we start getting wearing off between their medications. We start seeing it when they're at the peak of their med. They will have the extra movements like you've seen Michael Fox have on TV. Mm-hmm. It's called dyskinesia. And that will help start to limit us on how high we can go with their dopamine because it's at the peak. And then when it's low, they will get dystonias or cramping and twisting in the hands and feet, that type of thing. They can have dose failures where they'll take 5 doses a day and one of them won't work and the others work. They can have delayed ons over time where their medication doesn't kick on quite as fast as it used to. So these all affect them with their functioning on a daily basis.
What are the names of some of the medicines? The dopamine medicines?
There's 3 types. Dopamine itself, and we'll talk about that. Years ago, we started with that, and then we saw what happened long term with it, because the longer you're on it, the younger you are when we put you on it, and the higher your dose is the risk for getting those complications. So now we have looked to some other drugs, classes, and we start with those usually, and you may be 7 or 8 years into your disease before you get dopamine itself replacement. So we start with MAO-B inhibitors, which is monoamine oxidase inhibitor, and it's just a long name for an enzyme that breaks down your dopamine. So we're inhibiting that enzyme. So that's an early one we use early on when they come in, and what it does is keeps what dopamine they have left coming out of the cell. It boosts the levels by keeping it from breaking down. So that keeps it along, and by keeping that level higher and staying around longer, more of it gets onto the receptors. So their signal starts getting a little stronger again.
So
Then-
that's starting off with an MAO inhibitor.
Yes.
So that keeps the dopamine level up, and you use that before you start giving dopamine.
Yes.
And then
So,
what's
and they
next?
can get 2 to 3 years if they're a good responder with that medicine, where their symptoms will go away. But in several years, it won't be enough because they keep losing dopamine over time. So now it's not quite enough to keep that signal where it was. And then we add what we call a dopamine agonist. And there are 3 of those, and it's drugs that mimic dopamine. So they're designed to stimulate that receptor just like dopamine. So
Are they good?
then it fills in all the rest of the receptors that are empty now. So
So-
now the signal gets even stronger and more back to normal.
Is eventually that quits working also?
After they get 4 or 5 years with that alone, and then they go on and we add dopamine. But by being on these other drugs, it allows your dopamine dose to be lower. So you may be 7 or 8 years into your Parkinson's, and your dose would be half of what it would have been without those other drugs.
Before we go any further on the current treatment, I want to talk about the future, because there are 3 big things that have the possibility of changing the life of people that are getting Parkinson's. So let's go ahead and give that information out. Where is treatment going?
Treatment is going to longer and longer acting dopamines, so we won't have that pulsatility, and we think that will change those long-term complications. It is going to, we have surgeries besides the medications now. We have the deep brain stimulator, and that's
what's a deep brain stimulator?
It's almost like a pacemaker for your brain. Think about the cardiac pacemaker. It's put into the brain, in one on each side, into those areas, the basal ganglia, the motor part, and it's put in there, and then we stimulate it, and it stops their dyskinesias. So when they get those things, like you see with the extra movements, I remember I said it might limit us with treating them. When it does, every time we go up on their dopamine, their dyskinesias get worse. So all of a sudden, we are at an impasse on treating them. They can get the deep brain stimulator. It takes down some of their symptoms of slowness, a little bit of tremor, a little bit of the rigidity, but it doesn't cure the disease. So they are still on their medications, but they may be cut in half. But it takes away their dyskinesias. So now we can use dopamine for the next years of their life, many, many years of their life. So that is why they go to get that right now.
Heredity and stem cells. Tell me about where we're going with those.
Well,
We've only got a couple of minutes.
big interest is genetics in Parkinson's. We knew only 5% or so were genetic. Most of them are idiopathic, we call it, where it's not genetic. Now, every year we found 2 or 3 more genes, so they're predisposing genes, and we're up to 21 genes or more for Parkinson's. So that is bringing it up to 25% genetic. And then, so they're looking at that, and they're already trying to turn off the genes that one of them was more common, and they're looking at that one and what it produces, and if they can turn that off, then that may lead to genetic testing when people have symptoms and being able to have a drug directed exactly at what you have. And then there are I told you about the screening. We're going to be trying to catch them earlier. So we'll have drugs to slow the disease process down and catch them earlier with the screens, so they won't be down to 30% of their dopamine. And then, so it could delay the onset of their motor symptoms. Then in the treatment phase, which people who have Parkinson's right now are in, the drugs are getting better and better, so that they are living longer right now, but not going to stage 5 Parkinson's, which we used to see. And it's no longer a fatal disease. So they are functioning better, maintaining their mobility, being able to get around and do things better. And then stem cell is going to be, they're looking at stem cell now. So you will be hearing about trials that'll be starting with stem cell, and it is restoring the therapy by putting cells that can become dopamine producing cells into the brain.
Boy, huge advancements that are coming. You mentioned earlier that for the next several years, once a year, there's going to be a new medicine that's going to come out. It's going to be a good chance of coming out that will improve the lives of people with Parkinson's. I think it's absolutely amazing to me.
Yes, we had 2 in the last year that came out. One of them was the pump. There is now a Duopa pump that gives continuous dopamine 16 hours a day through the abdomen. So you have to get a J tube, But that continuous dopamine has helped people who can't get the deep brain stimulator or have a lot of trouble late in the disease. So it's smoothing them out, and they're doing much better. And they're able to give themselves extra doses at home when they need it. And then the other one was the longer acting dopamine came out, and it went from 2 hours to 5 hours.
So huge advances, huge amounts of things that we can do to prolong the life, to start early where the life is more functional. Michelle, the information is overpowering. It is absolutely fantastic. Thank you for coming to the Dr. Bob Show and telling us that the future for early diagnosis in Parkinson's will lead to a life that's, I won't say completely normal, but I will say nigh unto normal.
Better. And we tell the patients it's a time of hope. We're seeing so many things in Parkinson's, and great discoveries are being made.
Thank you for coming to teach. That means I'm going to have you back in a year or two to tell me what's gone on in the last 2 years.
That's right.
Thank you for coming to the Dr. Bob Show. It's been a great information state for me.
Thank you. Thank you for having me.
Fantastic. Need to know that the early diagnosis, so don't be afraid of early diagnosis. Be afraid of not going for early diagnosis. And now questions for you. We'll be talking about the connection between sleep apnea and obesity and different types of asthma leading to different types of treatment. A lot of information. You want to stay tuned. I want to thank Dr. Michelle Brewer. Wonderful discussion on Parkinson's disease. And now for questions from you, the viewer, that I think will be important to your health. Dr. Bob, is there a relationship between obesity and obstructive sleep apnea? Snoring, habitual snoring, sometimes leads to obstructive sleep apnea. 3 things that cause snoring: bad nose, bad throat, and bad belly. When people are obese, they have to work to pull the diaphragm. They have to pull to breathe, and that causes snoring. And if it closes off the soft palate, you have obstructive sleep apnea. While you've got obstructive sleep apnea, there are some things that are going on inside the stomach for some reason. There's a hormone called ghrelin, and ghrelin says go. It means go and get something to eat. I'm hungry. And when people are having sleep apnea, for some reason, that hormone on the greater curvature of the stomach tells people that they're hungry. When they're hungry, they eat more. They gain more weight because of their sleep apnea causing that hormone. The more they get overweight, the more difficult their obstructive sleep apnea gets. So yes, there's a definite relationship. Whereas when people have obesity and obstructive sleep apnea, it works against each other to continue to gain more weight and sleep apnea to be worse. So what do we have to do? We have to be sure that we exercise and eat properly, that we see a sleep specialist. If we need, we get on a CPAP. That will help the breathing better. The ghrelin will quit saying, I'm so hungry. It'll make it where you can lose weight better. Excellent question. Question number 2, Dr. Bob, is most asthma allergic? You know, it's a good question. Young people who have asthma, there's almost always an allergic component. As we get older, it may be an allergic component or it just may be asthma. What we are learning now with asthma in adults, there are different personalities of the asthma disease. We call it phenotypes. There's one that's eosinophilic. That's where a cell, the eosinophil, frequently associated with allergic asthma, seems to be driving the asthma. There's another one that's neutrophilic, where the neutrophils, a different kind of white cell, seems to be driving the asthma. And there are other types of asthma that we're learning that gives us information for new medications to form. There are new medications, we call them biologics. There's Xolair that works to block IgE. There's anti-IL-5 that takes care of the eosinophils. Those are medical terms. But know that not all asthma is due to allergy, but if there is allergy, you need to identify it, start on proper medications, and get on a desensitizing program. It's all the time that we have for this show. It's been a great educational show for me. Remember, what exercise can do. Exercise is probably the most important thing we can do. And it doesn't mean you've got to make all the muscles sore and that you've got to get out on a track and run. Any type of exercise, walking, but make sure that you're doing it 150 minutes divided into 5 times. So that's 30-minute, 5 sessions a week. So make it once a day and make it that 30 minutes. It will decrease your blood pressure. It'll make you sleep better. And when you sleep better, it'll make you perform better. It will cut down on stress. It will help you lose the pounds that you need. And 8 hours of sleep, we now think it's 7.5 to 8 hours of sleep. There's so many things that can cause sleep disturbance, and we now find that early Parkinson's disease can actually cause some sleep disturbance. So if you're not sleeping well, if you're wiggling all over the bed, if you wake up tired, if you're not resting well, talk it over with your doctor. It may be your medicines, it may be joint pains, it may be that you're just having abnormal sleep and you may need a sleep study. Eat properly. Remember, more fruits, more vegetables, less fried fatty foods, less volume of foods, and most of all, it's that laughter in your life. Laugh a lot, and you and I will stay healthy.